time with him, under him, and I can probably be proud enough to share that whatever little EP I know, it's because of him. Welcome, Professor Dheeraj Gupta, and I request the session to be chaired by Dr. Narasimhan sir, KC sir, and Dheeraj Gupta sir himself, and he can start off with his first talk if it's okay with him. Over to you, sir.
Well, thank you, Jay, for those very kind words. You are very kind and very modest. Now, it was a pleasure when we had you over here in Liverpool. Everybody remembers you very fondly, and we would love to have you again at any time. And hopefully we'll get to meet physically in a meeting in the future. So many thanks for giving me the invitation to contribute to this excellent meeting. I got the tail end of the last session, and I really enjoyed the last talk as well. So if you can hear me all right, I would like to say hello to my co-panelists and all the members of the audience who are attending. So I'll try to share my screen as I think I am doing the first talk.
Sir is there, and Dr. Chandrasekhar, I think they
Welcome, Dheeraj. Nice to see you.
Hi, everyone. Hello.
Looking
nice
forward.
seeing you on the screen.
Fantastic.
Dr.
How do you like my
told a lot
background?
about you.
Oh, that's don't believe everything that Jay says. He's too kind. Okay, so actually, I'm still in my clinics, but I've changed my background because it looks a bit prettier than my clinic background. Okay, let me start sharing my screen.
Yeah, thank you.
Okay, let's have a look. Can you see it all right now?
Yes.
We are seeing the slides. Okay, you can go ahead.
Great. Lovely.
Yeah,
okay. Well, I'll try to restrict my talk to less than 15 minutes because I believe that the best part of these meetings is the conversations and the discussion that happens at the end. So essentially, I've been asked to talk about how to set up an AF program. And the reason why I've been asked to do that is because when I moved up from London to Liverpool 15 years ago, Liverpool had a very nascent AF program. We used to do perhaps 50 cases a year. And we've gone from that to doing, we do about 600 or 700 AF procedures a year. And it's obviously not just my efforts that have resulted in that. It's a team effort. We have a very nice team of electrophysiologists who work together to try and get the best outcomes possible. But I have, in some small way, been instrumental in setting up the processes that have made this happen. So as I said, I have been in Liverpool since 2007, but before that, for 6 years, I was in London training with Professor John Cam, and before that, and after that with Richard Schilling. I head the arrhythmia research at the Institute of Cardiovascular Medical Science, which is a collaboration between the Royal Brompton and Hayfield hospitals in London and Liverpool Heart and Chest Hospital up in Liverpool. Now, before I talk about this, now, obviously, how to set up an AF program is very specific to the healthcare system where you work. Clearly, the demands and the challenges that you will face in India will be very different from the ones that I face in the UK. And I have to say at the outset that we have it very easy in the UK compared to what you guys have it in India. And I'll tell you why. The reason is we have a very safe hub and spoke model of healthcare delivery here. It's not very competitive like it is in the US or perhaps like it is in India. So we only have 38 ablation centers in the entire country. And we did about 10,000 AF ablation procedures between these 38 centers in the year 2017. Now, if you look at this map on the right-hand side, that's how those 38 centers are distributed across the country. And here we are in the northwest of the country, here up in Liverpool. Of course, this is only for England. This is Wales, and we have 3 centers in Wales as well. But these are all the centers in England, and these are the ones in London. So we have about 9 centers within London, in addition to these centers dotted up and down the country. Now, the EP activity in the country has changed from 2007 over the 10-year period, and the proportion of AF ablations has increased gradually. Now, if you look at the AF ablation per million population in England, you can see that it varies. So from over 200 per million in some pockets of Southeast England, where the population tends to be older, but also where we work in Cheshire and Merseyside, there are other areas within England where the AF ablation per million is much lower than 100. And very often, that's not a reflection of the demand on the surface of the service, is more a reflection of the of the facilities available and the supply. So hospitals which have geared up in AF ablation programs tend to do more AF ablation than other hospitals, because money really isn't a problem. NHS will fund AF ablation as and when it is indicated. So that is where we are in Liverpool. We have 11 district general hospitals that feed patients to us. So we are in a very privileged position that we are, all of these 11 district general hospitals, by and large, will feed their EP patients to us. Now, so that's the reason why we are the largest EP center in the United Kingdom. So this is, again, going back about 5 years. We did about 1,200 procedures that year. We do about 1,500 procedures a year. Obviously, last year was different because it was COVID, but by and large, we do about 1,400 to 1,500 EP procedures, of which half of them are AF procedures. Now, the three key considerations in my mind for a successful AF ablation program, and you can extend this to any program, whether it's gastric surgery, for example, or pacemakers or device work, anything, is safety, which obviously is the most important thing that patients are concerned with. Efficacy and ease of workflow, which is very important for us physicians. And throughput and efficiency, which is important for our managers, because they're the ones who have to balance the books. So if you really want to make your program fly, you have to have each one of these. Even if one of them is missing, you're unlikely to make the program work, because if your safety record is not excellent, patients will talk amongst themselves, your referrers will stop referring to you, and your program will stall. If you have got great safety, but the workflow is not easy, and there are lots of hurdles between patients having the procedures and getting discharged, physicians will tire off the protocol. And clearly, if all of these are fine, but if they're not making money for the hospital, or if individual procedures are taking a long time, there isn't a good throughput, you are blocking beds for days, then your administrators will put an end to the program, or will at least not let it flower. Now, speaking of safety, which I think is the most important consideration for an elective procedure such as AF ablation, I would accept a 10% less chance of a successful outcome, but I will not accept even a 1% risk of a major complication. I think if you go with that ethos, then chances are over time your reputation as a safe unit will give you dividends. So by and large, the AF ablation procedure has become safe over time anyway. Part of it is because it has become a routine procedure and we are all better at it. But partly it is because we've got access to technology that we did not have when I first started doing it 20 years ago. So for example, now we use vascular ultrasound to get access routinely, which means that the vascular complications has gone down. The incidence of tamponade is going down as well. In spite of us doing more procedures on uninterrupted anticoagulation, the incidence of tamponade has gone down because we do less extensive ablation. We just stick to pulmonary vein isolation as far as possible, either with radiofrequency ablation or with cryoballoon ablation. As the incidence of stroke TIs has come down as well, and similarly the other complications. By and large, we are already on to a winner in that there's no reason why AF ablation procedures should have a risk of complications, major complications of greater than 1%. And it's a behoven on every unit to audit their complication data carefully and over time. So perhaps at least every year, you should be auditing your ablation outcomes to see if you can make it better. Now, traditionally, the EP catheter lab setup used to look like something like this. So it was pretty complex looking lab. It probably still is. And in fact, you have all these 3D mapping screens and EP screens, etc. It can be a bit overwhelming for patients. Of course, things have changed a bit in the AF ablation world because now we have cryoballoon. I'm not sure if you have cryoballoon in India as yet, but it's definitely something which has caught the fancy of electrophysiologists worldwide. And we'll go into that discussion later on because I think I've got another talk coming up on comparison between radiofrequency and cryoballoon PVI. But it has become extremely popular because it makes the procedure much more straightforward for the operator, makes it more standardized for the administrators. And hence, it has really taken off in the last 5 to 10 years. And so the EP lab looks very different from what it looked 10, 20 years ago. And you might be aware there are some recent data where people are doing a cryoballoon ablation even without using EP equipment, would you believe it? Certainly, you don't need 3D mapping, so you can do it in any catheter laboratory, which is not equipped with 3D mapping systems at all. So it has kind of democratize the AF ablation program to smaller units, and that's happening in the UK as well. Indeed, if you look at the spectrum of EP cases now, it's very different from what it was 10 years ago. So AF ablation is no longer a complex arrhythmia. If you've done quite a few of them, especially if you've done cryo, if you've done 15, 20 of them, then, they're not really complex procedures. The transseptal access is potentially the tricky bit, which most electrophysiologists are very good at now. And then after that, it's dead easy. So if you look at the procedure times for paroxysmal AF, it's no more than it is for an SVT or a flutter. So 2 hours tops. And success rates, at least acutely, are as high, complication rates are as low. So there's no reason why you shouldn't consider AF to be a complex arrhythmia anymore. And you go with that mindset, and that is a very good place to start. Now, having said that, complications from AF ablation can still occur. And now, what are the factors that determine these complications? Now, this is a very controversial paper published a couple of years ago in JACC, looking at the morbidity and mortality data from AF ablations performed in the US when patients who were in inpatient. So not outpatient AF ablation, and can go into that, the reasons between the difference between those two, but these were patients who were admitted to hospital, had AF ablation. And this was over a 5-year period from 2010 to 2015. And what was worrying in these data is that there seemed to be an increasing trend of mortality following AF ablation. So that rather than going down, the mortality seems to be going up. And that may well be because there was an increasing trend in comorbidities in these patients. So historically, AF ablation used to be offered to patients with paroxysmal atrial fibrillation and very little in the way of comorbidities. But of course, now we take on patients with persistent atrial fibrillation, patients with structural heart disease. And obviously, those patients are going to be less suitable for a safe procedure than historically. The risk factors for early mortality following AF ablation was, well, procedural complications, which won't surprise you at all. Patients with background congestive heart failure, which won't surprise you either, but also importantly, low hospital volume for AF ablation. So if your hospital did less than 100 AF ablation procedures a year, or as an operator, if you did less than 50 a year, then that is a very strong predictor of complication in your unit. So that is an important thing to bear in mind, that as with everything in medicine, the more you do, the better you get at it, the easier it becomes for you. So if you are going to embark upon an AF ablation program, please do focus your energies on increasing the volumes. If it means having to let go of other things, then so be it. I know things are easier for me. When I started taking up AF ablation 10 years ago, I had to drop a lot of things. I had to drop extraction work. I had to drop device work, and then increasingly focus on AF ablation, left atrial appendage occlusion. And that's the reason I do 250 of these a year. But you don't need to do 250 of these a year. Even if you can do 50 a year, then that's probably good enough for you to maintain the level of competency that is needed to keep your complication rates low. Right, and so this is an excellent article I read in New Yorker many years ago from Atul Gawande. Now, you all know who Atul Gawande is. His books are amazing. If you haven't read his books, please do yourself a favor and read them. But this was an article which he had written called The Cheesecake Factory, the Cost and the Quality Conundrum. So he essentially went at the back of the Cheesecake Factory, which is a big, which is a big restaurant chain in the US, to see how come each and every dish always manages to taste amazing and always manages to taste the same. And he found three features of the work behind the scenes, which he thought could perhaps be extrapolated to the healthcare setting as well. A, standardization; B, oversight; and 3, economies of scale. And those 3 are the most important variables which will tie in with those 3 key criteria, which I put right at the start of this talk, which are important. So standardization will make for a ease of workflow. Okay, oversight, i.e. audit, will make for safety. Economies of scale is what your people, your managers will love, because they can get the cost down that way. And indeed, in our hospital, we tend to follow consistent intra-procedural protocols. So, everybody tends to follow the procedures the same way. We tend to, procedure times obviously come down with improvement in technology. We use ultrasound for all cases, EP procedures. We use uninterrupted oral anticoagulation. Everybody gets protamine at the end of the procedure before the sheets are removed. And so because of that, patients tend to have a seamless journey, pre and post procedures. So they come in the morning in a staggered way, the cases are done, and now 80% of our AF ablation patients go home the same day. So it's an exception for patients to stay in hospital rather than the rule, which is very different from the way it used to be about 5 years ago. So to summarize, current technology has allowed AF ablation to become safer. And again, I say safety, 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 most important consideration of all. High procedural volumes will remain critical for quality and safety. Standardized patient pathways will improve efficiencies. And these three ingredients are essential for a successful AF program. Thank you very much for listening, and I'll be very happy to take any questions.
Thank you, Dr. Dhiraj Gupta, for your lucid presentation on how to set up AF program. I think we have got 1 minute left. I think we can have a question from the audience or from the panelists. Dr. Jaishankar?
I think it should be okay, sir, because we're going to have a discussion midway through.
Yeah. Okay. Then I think we'll have the discussion at the end of the session, Dr. Dhiraj. Is that okay?
Midway, yeah.
We'll have the discussion at the end of the session. Okay, Dhiraj?
That's fine.
Yeah. Okay. Then we'll move on to the next talk by Dr. David Chase, and he's going to talk to us on early detection of atrial fibrillation, how to do and its significance. Dr. David, please.
At the outset, I would like to thank the organizers for giving me this opportunity to make a presentation on early detection of atrial fibrillation, the significance, and the how-to of early atrial fibrillation detection. Heart failure, thromboembolic risks, increased mortality, hospitalizations, and morbidity are all implications of atrial fibrillation, and the key to decreasing all of these hinges on early and more complete evaluation and diagnosis. Clinical AF is only the tip of the iceberg. Typical subclinical ECG identification happens in 3 settings. Among those with implanted devices that can record an ECG, among those who are being evaluated for another condition, and among patients who are being evaluated for embolic strokes of unknown origin. The problems associated with this group of subclinical AF is the high false positive rate for device-detected arrhythmia, unknown impact and significance of any abnormalities detected, as the evidence is lacking in this area. AF is multifactorial, more common in the older age group and among men, has a genetic predisposition, and is more common in the Caucasians. Valvular heart disease, heart failure, hypertension, diabetes, chronic kidney disease, obstructive sleep apnea, obesity, COPD, physical inactivity, physical intense activity have all been shown to increase the chance of AF, as also has binge alcohol consumption. Globally, atrial fibrillation is more evident in North America. India probably has fewer numbers. The male sex preponderance is quite evident from the slide. Minimizing risk factors for AF minimizes the projected AF occurrence, as evident from this slide. This slide tells us that since AF is related to aging, targeting older age groups is going to be useful. With higher risk factor burden, increasing AF risk gives us the opportunity to consider opportunistic screening of special populations and systematic screening of older individuals. The 2019 AHA-ACC-AHRS focused update of the 2014 AF guidelines has identified these two groups: individuals with a CID and AHRE, individuals with a cryptogenic stroke. The 2020 European Society of Cardiology guidelines has given little more clarity on approach in these patients. They have given a group level 1 recommendation for complete evaluation, including ECG for assessing thromboembolic risk and other comorbidities. They've also given a class 1 recommendation for informed screening, which means telling a patient the implications of ending up with a positive test for a screening test, the referral to be followed, and a class 1 recommendation for physician review based diagnosis of clinical atrial fibrillation using a 10-second 12-lead ECG or a 30-second single-lead ECG. Many of us will be familiar with this type of situation where a CRT patient on follow-up has loss of pacing due to increased ventricular sensing due to AF or atrial flutter, which was the case in this situation. Patient had moderate systolic dysfunction and dilated left atrium. The European Society of Cardiology has looked at these two categories of patients, those with CID and having AHRE, those with the implanted cardiac monitor, loop recorder, which has documented AF, and they've suggested performing an ECG in all these patients. Those with the negative ECG fall into the category of subclinical AF. Among those with atrial high rate episodes, those with longer duration AHRE episodes to start with for 6 months, progress and have even longer episodes of AHRE. Stratified based on CHA2DS2-VASc score and duration of AHRE detected by device among stroke patients. Stroke risk was higher among those with a higher CHA2DS2-VASc score and among those with the longer duration of AF. A meta-analysis which looked at all studies that have shown a link between AHRE episodes and thromboembolic risk has just come out, and the conclusions of this meta-analysis are that single AHRE episodes that last more than 30 seconds or cumulative AHRE duration more than 24 hours increases the risk of stroke or systemic embolism. This is also consistent for the group of patients who have single AHRE episodes that are longer than 5 to 6 minutes or longer than 6 hours and longer than 24 hours, all suggesting that those with AHRE need to be followed up closely. The European Society of Cardiology guidelines for such patients who are on a CID with long duration AHRE, as depicted here, lasting more than 24 hours with a higher CHA2DS2-VASc score, should be considered for oral anticoagulation therapy. Older patients than 65 years age lend themselves to opportunistic screening, therefore, and those older than 75, where anyway AF risk is even higher, lend themselves to systematic screening. The benefits of screening for AF include early treatment and prevention of thromboembolic episodes, as well as symptoms and other benefits. The downside is that abnormal results cause anxiety, over-interpretation, over-diagnosis, over-treatment with false positives or true positives, resulting in complications related to over-investigation. All need to be borne in mind. Various devices are available for assessing subclinical AF. Nowadays, blood pressure monitors have a built-in system for recording ECG. Standard pulse examination is a useful tool as a screening method. Photoplethysmography from smartphones, wearable devices, smartwatches, wearable belts, or standard ECG recording from various devices, as well as limited ECG recording from Holter monitors, 1 to 2 week monitors, insertable cardiac monitors, patients on follow-up post-stroke or during hospitalization with telemetry. There are all different ways and means of documenting intermittently or continuously atrial fibrillation. Other devices are available which allow patient initiated or physician initiated intermittent ECG acquisition for documentation of AF. A particular study involved the use of a live core device, and this device helped diagnose AF better than the routine follow-up category of patients with cryptogenic stroke. The sensitivity and specificity of these devices has been proven to be fairly reliable. These devices use different mathematical formulae for deciding and differentiating between atrial fibrillation and sinus rhythm. Motion detectors help avoid noise that could contribute to wrong overdiagnosis. RR interval algorithms help in ECG, and peak-to-peak pulse variability algorithms help in photoplethysmography for detection of AF. Devices which allow single lead 1, 2 electrodes. Devices which allow wrist, skin to contralateral thumb ECG channel recording, as well as 3-channel recording, including chest leads, is possible with such devices. These devices, which allow simultaneous ECG and plethysmography, have a more reliable and accurate yield. We have 2 sets of tracings here. The top set of 2 showing a regular rhythm with a regular RR interval, and bottom set an irregular rhythm, such of AF. The next panel shows sinus rhythm tracing with peak-to-peak plethysmogram assessment during sinus rhythm and during atrial ectopy, where a long shot event is documented. These devices are better able to document and differentiate between AF at slower heart rates between 50 and 100 beats per minute than at faster heartbeats. Subclinical atrial fibrillation is the submerged portion of the iceberg that is not evident, and looking for it has its rewards and is available only for those patients who subject themselves to assessment. A real tool that could predict AF in a given population would probably be available from this study. for the future, which looked at deep learning. It is a 5-year AF prediction algorithm, and compared to a 11-question risk score, it did better at identifying people who are potential for 5-year prediction of AF based on deep learning. In future, randomized controlled trials may give us better understanding about how to approach these patients and what thresholds ought to be used to decide on management of these patients, especially with regard to treatment modalities which could cause complications such as bleeding problems. Thank you for your attention.
Thank you, Dr. David Chase, for your great presentation on early detection of atrial fibrillation and what are the various aspects of detecting atrial irate episodes and what are the significance. So we'll have the discussion at the end of this session, and the next talk by Dr. Muralidharan is cancelled, and we'll move on to the next talk by Dr. Haigriv Rao, and he'll be going to talk on non-pulmonary vein triggers in the pathogenesis and management of atrial fibrillation. Dr. Haigriv Rao, please.
Greetings. At the very outset, I thank Dr. Jaishankar and his team for organizing this symposium and giving me an opportunity to talk in this symposium. My topic today is non-pulmonary vein foci in atrial fibrillation. The electropathology of atrial fibrillation is very well known. It is basically an interaction between triggers and substrate. This is the concept that is there since many decades. And of these, it is predominantly believed and proven that triggers are the ones which initiate atrial fibrillation, and the substrate sustains the atrial fibrillation. And the entire management of atrial fibrillation, the ablative therapy in particular, has focused on the elimination of triggers. Before we talk in a systematic manner, there are two important data that come to my mind when we talk about the non-pulmonary vein foci in atrial fibrillation. The first one is Dr. Mohan Nayar's paper in Circulation, summarizing the work done in G.V. Pant Hospital into very, very early 2001, where he had patients, 17 patients with who had undergone mitral valvuloplasty. They're all rheumatic heart disease patients, and had chronic atrial fibrillation. What he showed was 14 out of the 17 patients had organized atrial activity coming from the CS os, initiating the atrial fibrillation. So this was probably the earlier thoughts on the non-pulmonary foci on atrial fibrillation. And similarly, in 2005, when I was working with Dr. Sanjeev Saxena, we studied 50 patients with atrial fibrillation. These had both structural heart disease and non-structural heart disease. Because this was in the United States, there was no rheumatic heart disease in them. They were structural heart disease, non-rheumatic. And in these patients, what we found was among the patients with structural heart disease, showing by the black bars, these had a more extensive distribution of triggers, both in terms of PACs and organized atrial arrhythmias coming from the different parts of the left and right atrium. So both these papers basically show that in patients with structural heart disease, there is a predominance of non-pulmonary foci arrhythmias. However, these papers apart, the main thrust of pulmonary vein, the atrial fibrillation lies on the ablation of the pulmonary veins, because of this classical paper by Hesseger, where 45 patients had were studied and 69 ectopic foci, 94% of them came from the pulmonary veins. And this heralded the era of pulmonary vein isolation for the management of paroxysmal atrial fibrillation. Now, what to ablate and how much to ablate over the period of time took a lot of changes. Now, these are the patients which Hesseger described. This is a patient in our lab which has a right superior pulmonary vein origin of the atrial fibrillation, but there are patients who have the LSPV, RIPV, and so on. So, and some of them require the isolation of all the four veins. Now, whatever said, the pulmonary vein isolation took off, and it became the standard of care and the guideline-directed therapy for atrial fibrillation. So the lesion patterns, however, they differed. So initially it was a focal ablation, but then this was resulting in PV stenosis, and then this changed over to the circular lines around the PVs. And then came the line around a wider line involving the antrum. Here I would like to say that when a wider line is made encircling the pulmonary veins, it actually involves the antral non-pulmonary foci also, and it addresses them. So this is the beginning of the non-pulmonary vein isolation. Now, the problem with the paroxysmal AF is totally different from persistent and long-standing persistent atrial fibrillation. These two are colloquially also called as the chronic AF, the long-standing persistent and the persistent AF. Here, what you can see is it's not just the lines. This star A2 AF was published in NEJM. They actually studied 1:4:4. What they studied was the pulmonary vein isolation compared with the electrograms, complex electrogram ablation, and the lines. But what was found was there was no difference. So pulmonary vein isolation was as good as these things. So these lines are supposedly addressing the substrate. But in fact, we can retrospectively say that they also address some of the non-pulmonary venous foci. Now, when you look at the evidence of non-pulmonary venous foci, it is seen from the recurrence that occurs after PV isolation. Now, 80 to 100% of the PV recurrences after AF ablation occur because of the reconnection. However, a percentage of the patients also here occur which are not because of the reconnection. That means despite an excellent pulmonary vein isolation, they have recurrence. And this is thought, and this is one of the hypotheses thought that there are triggers coming from sites other than the pulmonary veins. And now the non-PV triggers are the ecto-PV which lie outside the PV and initiate the AF. This is because of the myocardial cells that retain the ability to depolarize and they serve as a substrate for re-entry. And this is exactly what happens. You can see that the pulmonary vein sleeves, muscle sleeves extend into the posterior LA. The CS-os muscle extend into the RA, and the SVC extends. And all these things, muscle sleeves, these are the cells which act as the triggers. Now, 15% of the patients who undergo AF are thought to have non-PV triggers, but the definition, it depends upon the definition, number one. Number two, the mapping technique, how many catheters are used. And second thing is the strategy. Are you using a high-dose isoprolene or a low-dose isoprolene? So there is no standardization, but large studies approximately show 15%. So the sites of non-PV triggers are the inferior mitral annulus, the interatrial septum, the left atrial appendage, the eustachian ridge, the crista terminalis, and superior vena cava. There are other sites like persistent SVC and the remnant ligament of Marshall. So there are various non-PV sites of triggers. Now you can see the distribution of non-PV sites of triggers, and in paroxysmal, persistent, and long-standing persistent, shown by the red, blue, and violet, and the green, you can see that this is a wide distribution from the SVC to the IVC and the CS-os, the LA appendage, and these are more common in the long-standing persistent atrial fibrillation and persistent atrial fibrillation than the paroxysmal atrial fibrillation distribution-wise. The very recent paper from Xian Chen's lab shows that if you look at the distribution of the foci, the pulmonary venous foci with respect to age, they actually had a large 1,500 patients they took, and these patients from a long period of ablation from 2003 to 2016, they divided them into 20 years, less than 20 years, 20 to 40, and 20 to 40, 40 to 60, and above 60. So they called them as young, middle, and old age respectively. And what they found was that in the PV, so when the foci was PV, there's a paroxysmal AF, the young, middle, and old, all of them had similar PV foci. But when you look at the non-PV foci and PV, again, the younger people had more often the non-PV foci. And when you look at the patients who had non-PV foci only, predominantly it was the younger age people. So what he showed was that when you have a patient with a younger age that is less than 40 years, 20 to 40 years patients, the chances of having a PV, non-PV foci are much higher. As patients become older, the non-PV foci triggers are much less important. The distribution of foci in another huge paper by from Japan, about 3,000 patients, out of them 534 had non-PV foci, showing that about 19% of the patients of AF had non-PV triggers. And here, predominantly they were distributed among the RA and LA, and you can see that the SVC triggers predominate, and so do the IAS. Then there is an equal distribution among the different kinds of triggers. Now, if you look at the again Xianchen's paper, where he looked at the different sites and compared with the ages, the young people had again predominantly SVC triggers when compared to the middle age and the older people. And as you can see, the other sites, the younger people are far much less, showing that. And the comparison was 8% versus 3% versus 3% at different age groups. And similarly, if you take a non-paroxysmal or persistent AF, again the non-PV foci were more common, and these were more common again in the young people and more common in the SVC. So if you look at the overall paper, you can see that the non-PV foci are much more common in the younger population when they present with AF, and among them the SVC seems to be much more common. Now, what are the clinical characteristics which determine that a person may have a non-PV foci? These are clinical characteristics: a non-paroxysmal AF, female gender, and in general it's considered older age. The Xianchen paper is the latest thing which shows that it is more likely to be the younger age. Obesity, sleep apnea, lower EF, LA scarring, hypertrophic cardiomyopathy, and mechanical mitral valve late recurrence post PVI. So these are generally considered as the patients who have a non-PV triggers, because if you have these clinical characteristics, some of the labs actually ablate them. Now you can see the mapping strategy is very important, how to map them. So typically what is required is a duodecapolar catheter extending from the SVC into the CS, which maps all these areas. And then you have a circular mapping catheter into the, which is going to record the LA appendage potentials, which are the far field potentials, and the ablation catheter, which will record the interatrial septum. So you can see the patients who have a earlier interatrial septum, and this is a example of a patient who has a CS trigger, and this is an example of a patient who has an SVC trigger. The PR interval is longer, but otherwise it appears like a sinus rhythm. And the earliest activity is SVC trigger, and you can see the next thing where you have a CS trigger, but there is no electrograms in the LA appendage because the LA appendage in this particular case has been isolated. So these are the examples on how to map the mechanism of mapping, and it is important to have this kind of extensive mapping systems and catheters all over. Now you have used the circular mapping catheter. Now you can see the different frames of this image showing the circular catheter mapping. Catheter is being moved across the posterior wall and recording the electrograms at different places. And based on that, the ablation is carried out. And you can see on the right panel, as the ablation is carried out, the electrograms completely disappearing in the posterior wall. And a 3D map shows an extensive ablated scar in the posterior wall. And you can see all the ablation signals, which are extensively distributed in the posterior wall of the LA. Now, the ablation strategy over the different institutions is patients with non-paroxysmal AF, they actually initially all of them undergo the pulmonary vein isolation and a posterior wall isolation. And there are some centers which do, this is strategies from the Natale's lab, the left atrial septal ablation and ablation of the roof. These are the empirical ablation they do in patients with non-paroxysmal AF. And after that, the patient is challenged with isoproterenol and to look for inducible non-PV triggers with all the hardware in the heart. And if the inducible non-PV triggers are seen, then these are ablated. And if they're not ablated, and if there are clinical characteristics like I alluded to in a few slides back, like obesity, sleep apnea, mitral valve, and these are the patients whom they will empirically go and ablate all these areas like left atrial appendage and the CS. But if nothing is found, if the clinical characteristics are not there, and if there is no inducible non-PV triggers, they would not ablate further. Now, what are the results of these ablation results? Now, Inamura, again, is a large series of 3,000 patients. They showed the ablation results on paroxysmal results. What you can see here in the left is that patients were about 1,100 patients were paroxysmal and 400 were non-paroxysmal. What you can see is that if you have a patients with PV isolation alone, the results are about 76% at 3 years. But if you have RA foci, it drops down to 68%. But if it's the LA foci, it drops down further to 54%. So the LA foci, non-PV foci actually are much less, results-wise, they're much less encouraging. And if you have a SVC foci, this is the most encouraging because the results are as good as the PV isolation, 76% versus 72%. Whereas if you have an IS foci and a CS foci, again, the results are 64% and 59% the 3-year ablation rates. So what clearly it shows now in the conclusions is that non-pulmonary foci for AF initiation is an important entity, that the clinician who manages an ablates atrial fibrillation must be clearly aware of. It predominantly contributes to AF recurrences post-ablation if these are not sought in the initial stage. So in all the advanced high-volume AF centers, it is recommended that after PV isolation, particularly for the non-paroxysmal AF patients, that they look specifically for the non-PV foci and induce them by isopropanol and ablate them. Extensive mapping with multiple catheter helps to identify these foci, and RA triggers are much better results-wise when compared to the LA triggers, and among them, the SVC foci have generally the 3-year AF fee interval is as good as the PV isolation, which is done for paroxysmal. Thank you very much for the patient here.
Thank you very much, Dr. Haigreve, for bringing out nicely what are the non-pulmonary vein triggers, right side, left side, what is the pathogenesis, and what is the importance of doing the ablation when you identify the non-pulmonary vein triggers. I think we'll have further discussion later at the end of the session.
Sir,
thank you, and we'll move on to the.
Sir, you can take questions now. We are back on time because one talk.
Yeah, okay, yeah.
So Professor Dheeraj is also there if you want to ask him. And there's one or two questions in the chat box, sir, if you would like to take those questions.
No, I can't see anything here.
Sir, the Q&A la parunga, sir.
While he's looking at it, Professor Dheeraj, welcome, and we're really excited to hear from you because such a vast experience. Truly appreciate the work that you've been doing. I just wanted to know, what do you think about the posterior wall isolation? I think you have such a large volume. You need to kind of probably randomize and see whether it makes a difference at all. Except for one group which has been pushing this posterior wall isolation. You do a cryo and isolate, I think. What is your opinion? What is your take on this?
Yeah, well, first of all, Narasimhan, the pleasure is entirely mine. It's such a pleasure to interact with you, and I hope we could do it in person sometime soon.
True.
No, I think your question is very relevant. We don't know the exact role of posterior wall isolation. There are some centers which have been, as you say, which have been pushing it, and in particular one group from the US. But the jury is still out. There was in fact, I'll be covering this in some detail in my talk on persistent AF.
Then probably we'll listen to you.
Some of the questions will be answered then. But let me just tell you, your question is very topical because we've just started a multicentric randomized trial called RabLab AF, of which I'm the chief investigator. We got 11 sites from the UK, 2 from Belgium, in which everybody with persistent AF is going to get a loop recorder 2 months prior to their procedure. Then they're going to be randomized to either having PVI or PVI plus posterior wall isolation. And then the follow-up is going to be via loop recorders to look at AF burden over 3 years. So that the trial has been, it's on clinicaltrials.gov, and I can send you a link as well to have a look at the protocol. So hopefully we'll get the answer. Of course, as it happens with these trials, it will take time. The answers won't be forthcoming within the next year or two, but we do need a randomized trial. I agree with you entirely.
Sure. Thank you.
The question on the chat box is, what are the outcomes of AF ablation and rheumatic heart disease? So Professor Dheeraj or Professor Narasimhan, sir, one of you can take this.
Well, thanks, Jay. I can certainly try to answer this question, although as you know, from having worked in Liverpool, we don't really come across patients with rheumatic heart disease quite so much. Now, when I was working at All India Institute many, many years ago, when I was doing my DM there, we used to have lots of patients with rheumatic heart disease, but AF ablation was very much in its infancy. In fact, it was that was a time when pulmonary vein isolation triggers were first described. So as I can only go based on published data, and there are some data from some collaborative work that has been done by from Prash Sanders group, with some with the Sri Lankan operators. So essentially, the outcomes are very much the outcomes are less good as compared to patients with AF without structural heart disease. That doesn't surprise anybody, as we saw. And in fact, it was a very, as it was shown just now also, that the extent of non-PV triggers depends upon a lot of factors. And one of them is, mitral valve disease. If you've got extensive mitral valve disease, you've got large left atrium, then pulmonary vein isolation alone is unlikely to be effective. So the results are less good, but they are dependent upon the patient's left atrial size, is what I would say. But as I've only done a handful of these patients, and if Dr. Narasimhan, if he has more experience, then I'll be really interested in hearing that.
Yeah, we have close to about 14 patients thus far, and you're absolutely right. Very often we find the PVs are almost auto-amputated. You don't find much of potentials because of the fibrotic process, and it's more often LA flutters, free wall, or they have flutters, roof-dependent flutter, and so on and so forth. And because it's an evolving substrate, some of them tend to come back with the problem. One of the things interesting we noticed is you have scar where the MR jet hits the posterior wall. So where the mitral regurgitation hits the posterior wall, that area seems to be highly scarred and forms a substrate for re-entry. And the results are not as good as in idiopathic AF, non-valvular AF.
I agree with you entirely. In fact, if there is some time, I might show you a couple of images, because I presented this very interesting case at the European Heart Rhythm Association AF ablation workshop. And this is a patient with rheumatic heart disease from Sri Lanka. She came over with lots of AF and she was referred to me for ablation. And absolutely right, Narasimhan. We found so much of scar on the posterior wall. So when you said this, it kind of stuck, it resonated with me, because that's exactly what we saw in this patient. She had the substrate for multiple flutters, roof-dependent flutter, even perimitral flutter. So yes, just because of so much of de novo scar, it was a problem. So I will show you the carto map of that patient. I'm just downloading that presentation from my iCloud drive. So in the meanwhile, we can take some other question.
Dr. Dheeraj Gupta, you in paroxysmal AFib ablation, do you go look for non-PV triggers, or you'll just isolate all the 4 pulmonary veins and be done with it?
Thanks for the question, Dr. Chandrasekharan. No, our approach very much is pulmonary vein isolation driven. So for the first procedure, it's much better to concentrate on giving the patient the best quality pulmonary vein isolation you can do, something that will achieve PVI durably and safely. And then we will see if the patient continues to have AF recurrence in spite of durable pulmonary vein isolation. That is the time then to look for extra PV triggers. I will also say one thing. I found the talk on extra PV triggers fascinating, especially the data on I think Dr. Rao presented the data on the higher incidence of non-PV triggers in patients at either age spectrum, patients younger than 40, I think older than 70 or 80. Well, I would say that anybody who enters a lab who's less than 40, who has AF, we always start by doing a basic EP study first, which I think most of you would do as well. And it's surprising how many times you get patients with AVNRTs or concealed left ventricular pathways or something. And very often those patients we would just isolate. We would just ablate that target rather than isolating the veins.
Thank you so much.
Casey, sir, should we move on?
Yeah, you can go ahead with the next one. Next talk.
So, good friend Gopal will talk on identifying signals and targets for ablation in atrial fibrillation. Welcome, Gopal. We can see you, and the presentation can be put on, please.
Hello and good evening. I thank TNEPIC organizers and my sincere thanks and respects to Ishak for an invitation. My task is to talk about atrial fibrillation, identifying signal and targets for ablation. Most of the slides I may put forward are very basic, but these are some slides which may be relevant for perhaps the beginner. So what are the markers of success? What we try to achieve is to get successful ablation towards better clinical outcome in the short and the long term. And what are the markers? A is case selection, and the best cases are paroxysmal by far, and that's not changed for many, many years. Sooner we ablate, better they do. Once they become persistent or permanent, the less likely you're going to get success. Of course, anatomy, not just knowing the anatomy, but anatomical correlation to AF ablation, as it is largely anatomical. And of course, signals, which is what we're going to talk about today. So all these three, however, with AF ablation, it is a balance between safety and outcomes. So more you push, you will get better outcomes, but then it does compromise safety. So one has to balance these two. Coming to the anatomy, I don't need to spell out much in terms of cardiac anatomy to electrophysiologists in the crowd. But any anatomy, I think one has to bear in mind that there can be variations, and only 60 to 65%, as we know, have this typical four veins, two left, two right veins. Almost 35 to 38% of patients we know have abnormal venous anatomy. And if you have abnormal venous anatomy, then one has to know that that is the case while you try and start an AF ablation case. It is relevant as we move to different technologies. Let's say in this case here, you have an abnormal right middle vein. And if you have sleeves into this, you will have to ablate that. That has to be borne in mind. Obviously, if you do a VACA, then you will cover that aspect. But if you have a large left common like this, technologies like cryoablation may not work because your balloon will just not go on a clue, and therefore it is very difficult to get a good outcome with vein anatomies like this, which can be up to 30% of your cases. Not only knowing the anatomy, as I mentioned, safety is important. Knowing the proximity of nearby structures are important, which is why I put this dissection slide here. You can see here a left lateral cross-section showing the proximity of the esophagus to the posterior LA wall. This is another color-coded anatomical CT scan. You can see the esophagus in yellow and how close it is to the left atrium. This is another picture on the CT scan where you can see the proximity suggesting the ease with which one can overburn or perhaps perforate to create tracheoesophageal an LA esophageal fistula. This is an important slide to understand the anatomy so that we target what we're ablating. This just shows the sleeves, the muscle sleeves extending from the vein into the LA, or perhaps vice versa. It is indeed these sleeves that conduct ectopics from the left atrium, from the pulmonary veins into the left atrium. And what we are trying to achieve here is isolating these sleeves from conducting into the left atrium. That's the whole idea of AF ablation, i.e. pulmonary vein isolation of AF ablation. This is another view of the sleeves, the direction of the sleeves from below upwards, and the posterior wall also, which you can see very nicely. This is a very important aspect one has to bear in mind. This is a cross-section histology. You can see the muscle sleeves, and these are the sleeves that one has to target towards ablating. You can see here, it is important the burn here from the lumen of the left superior, left inferior has to reach the sleeve, burn it, create necrosis so that there is absolutely no conduction on either side. That is what we are trying to achieve. On the longitudinal view on the bottom of the slide, you can see here the vein on the left-hand side and the atrium, and you can see the brown muscle sleeves, which is what you're trying to isolate through an antral isolation technique, be it with RFA or just at the OS with cryo. This is a slide to show you the friend. We won't go into this in detail. In terms of ablation and signals, it's largely down to what technology you use. Largely it's RFA with 3D, which is what everybody uses. Cryoablation is new, it's coming. Laser PBI and surgical are other options which are largely not adopted in our country. I will show you an example. This will be largely now into signals. This is a patient who has normal sinus rhythm at baseline, trouble with paroxysmal atrial fibrillation, and we start with catheters. We take a CS and an Optima. You can see here, and the routine setup is we do a wide area circumferential ablation with a carinal line. So it's a figure of 8 that I do for both the left and the right set of veins. A DECA in the CS is standard, 2 transeptals in all patients, 1 SRO and 1 SLO, and one takes the Optima and the other takes the ablation catheter. Agilis I take rarely, to cut down costs, and usually we get away unless we're dealing with the left atrial tachycardia, where you need precise manipulation of your sheath and the catheter. And the irrigation technology is always a Coolflex irrigation RFA catheter. And attention to detail, I can't stress more. It is largely down to attention to detail that I have seen, at least from my practice, that achieves good outcomes. Standard setup, I won't go into this. I take a lot of time creating a very detailed geometry. It's worthwhile getting the geometry right and making sure your patient does not move either by deep sedation or GA if you need be, because if your 3D anatomy is not precise and it's not stable, then it is unlikely one will get a very good or an easy good outcome. Once the anatomy is well drawn through 3D mapping, we get on with mapping our signals. So initially I start with a right approach, because the right veins are more difficult to get. So I would prefer to do the right sided veins first and then go to the left sided veins. During the transeptal, it's important one gets as anterior puncture as possible, because it's important, otherwise you will not be able to get the septal side of your vaca for the right veins. So the spiral is in the right superior pulmonary vein. You can see here the vein is well connected in sinus rhythm, and these are RA signals and LA signals inside the right superior pulmonary vein. We get a baseline. I am pacing from inside the right superior pulmonary vein. You can see here the vein is clearly conducting into the atrium, as evidenced from signals from the CS, also showing that there is clear entry from the vein into the atrium, suggesting we need to get an entry and an exit block. We'll get on with the ablation, standard ablation, and these ablations are carefully performed to make sure every burn is a good burn with good contact. Of course, you can use Tacticat. I have not demonstrated that, but it's important to get contact and prove it with an impedance drop and clear loss of signals with every burn. If there is an incomplete burn and you end up moving very quickly, you may end up generating edema, which can falsely give you a sense of security that there is no conduction, which might later recover. So you want one burn and necrosis right at the first burn, and not an incomplete touch and go, which could end up with edema and then give you a false sense of security. That's very, very important. Taking time here is important, and getting your inter vein line is also important, I feel. This is just showing you the posterior wall. We go carefully. We reduce the wattage down to 25 watts standard for posterior wall, and 35 or 40 in the anterior wall, sometimes 40 near the groove, near the LA appendage and left superior, which is the thickest part of the atrium. Once all the ablation lesions are done, so I just do a complete anatomical vaca with line. So don't look at the signals at all. Once you finish that, then now you're going to look at the signals to see if there are any gaps, and that's when you're going to map this electrically and find your signals and get rid of them. So here the vacas are done. So we start mapping the signals for any gaps. Here you can see dissociation of signals as I start ablating, and my right superior pulmonary vein here, you can see here, is being isolated completely. Once it's completely isolated, there are no signals inside the right superior pulmonary vein. Then I move on to the right inferior pulmonary vein. It can be very depressing after a big vaca. You see signals all along the right inferior pulmonary vein, but doesn't matter. Usually there is only one gap. You just need to put out your sweep speed and see where is the earliest signal. Here I can see the earliest signal is somewhere 11, 12, 13, 14. So I get my ablation catheter ahead of that, and you just have to give a single burn. And with that, you can see here that gap is burned and you get complete isolation. So that's pretty much what you need to do. And that completes the right superior and inferior pulmonary vein. So right inferior vein is now ablated. Once you ablated, now you want to make sure there is exit block. Now I'm pacing from inside the vein in the right inferior pulmonary vein. I have made sure that we have capture from within the vein by seeing near field potentials in my optima, and there is no capture in the CS catheter, i.e. in the left atrium, demonstrating that we have achieved exit block in the right inferior pulmonary vein. Similarly, the right superior also has to be performed meticulously to make sure we achieve our endpoint. This is just a snapshot of isolation and exit block on this screen. Now, again, I went up to the right superior pulmonary vein, checking for signals, and if there's any signals and gap, then you just have to map and ablate it. Moving on, now this is, I move to the left superior pulmonary veins. Now, we have already completed the vaca. Now we just want to look at the earliest signal, and we just have to ablate the earliest signal. Here you can see here, my earliest signal is somewhere 9, 10, not 9, 10, 11, 12, and ablating here achieves complete left superior pulmonary vein isolation. You can see here on the screen. And once it's isolated, it is not uncommon that as you're isolating, you will see the signals that has gone away, that has come back. This is a slide demonstrating that. It just suggests either my contact is not good or I'm not exactly on the spot, I'm slightly away, which means you have to move closer and give a better burn. This is a demonstration of these signals coming back, and then you will have to ablate again, achieving successful left superior pulmonary vein isolation, which you can see on the screen here. Once that is done, exit block has to be demonstrated. This is from the left superior pulmonary vein. I'm pacing from inside the vein using my optima, demonstrating a left superior pulmonary vein exit block in this case. Often you will end up seeing these signals. One has to demonstrate that these are indeed far field from the appendage, and what you need to do is to move your catheter to the appendage and pace from the appendage. And when you do that, you see the signal sucked in, as you can see on this case. This is just another snapshot of the signals I've just shown you about the baseline signals, then ablation, and then the exit block as demonstrated. Next, I move on to the left inferior pulmonary vein, and here again there was just 2 signals, and one has to just find out the earliest signal there, and I paced from there, demonstrating they were indeed true signals because there was no exit block on this screen. And here you can see here I'm just ablating in the earliest point of ablation catheter, and once that is done, you can see here catheter knocking on the ablation signal, demonstrating I'm very close there, and the signals were gone. And subsequently, I wanted to do an exit block, but before that, I had 2 ectopy. You can see here from the left inferior pulmonary vein that did not conduct, demonstrating through natural ectopics that there was indeed exit block. But then, if you're paranoid like me, I did pace 2 to demonstrate near field capture from the left inferior pulmonary vein and still demonstrate the same exit block in the left inferior pulmonary vein. So that's all 4 veins done. So entry block and exit block in the left inferior pulmonary vein. This is a snapshot of all that. So this is just a signal demonstration of all the anatomical lesions that I have delivered. The yellow spots are the gaps that I had to fill at the end, which is good to keep it. Usually we wait for 20 minutes and go back so that if there's any signal, we want to get back to that point. So to conclude, attention to detail, I think, is key in my opinion, and taking things slow and making sure every lesion is as perfect as one can possibly achieve. Good quality ablation lesions are important, looking for impedance drop and no signals. These are key to me, and I'm making sure at all times I'm watching the impedance signals. Of course, tachycath is very useful, but slightly makes the procedure more expensive. Entry and exit block demonstration is key, and I couldn't stress more. And it might be time consuming and irritating sometimes, but it's worthwhile. I would wait normally 20 minutes, check with adenosine, and if there's reconnections, then you'll have to reaccelerate again. I would normally wait another 20 minutes if there was a reconnection, and then ablate it again. And doing this 20-minute cycles, making sure there's no reconnection is important. It might be that you're just sitting there twiddling your fingers, but I think it's worthwhile doing that to make sure the patient doesn't come back again with AF. Induce AF. Sometimes we, if it's a redo, I would like to induce AF, and if there is for paroxysmal, then I might resort to cafe ablation just to minimize substrate, to minimize perpetuation of AF. I would avoid all linear lines and paroxysmal, and if at all you end up doing lines, it's important to make sure you achieve bidirectional block across those lines. Thank you.
Thank you, Dr. Gopal Murugan, for your excellent talk on the identifying the signals and what are the targets for ablation. Very nicely brought out the basic steps in identifying the signals, how to go about in doing the ablation, how to get rid of the PV signals, how to demonstrate the exit block, entry block. Very nicely demonstrated. I think we'll have the discussion at the end of the session. So we'll move on to the next talk by Dr. Lawrence Jesuraj, and he'll be talking to us on cryoablation for atrial fibrillation. Where do we stand now? Dr. Jesuraj, please.
Hello. Hi everyone. My sincere thanks to the organizers, particularly Dr. Jaishankar, for giving me this wonderful opportunity to be among with you. My topic for discussion today is on cryoablation. Cryoablation for atrial fibrillation, where do we stand? We know very well, early treatment of atrial fibrillation is most important. You have to treat atrial fibrillation when it is paroxysmal or in the early part of its pathogenesis. AF is a progressive disease and early treatment is very important. After 10 plus years, around 50 to 77% of the patients who receive medical management will develop persistent or permanent AF. We know very well when you are going to try anything at this pace, is it a persistent or permanent AF, your response rate is extremely bad. The progression of AF is associated not only with adverse clinical outcomes like heart failure, stroke, mortality, and cardiovascular hospitalization. It also has a lot of changes in the LA. So it ultimately leads to a lot of LV remodeling. So most of the possible treatment options, like maybe your drugs, maybe your catheter ablation with radiofrequency or cryoablation, all become less effective. Need for AF is ever growing as the population across the countries have more and more aging population. The incidence of AF is going up, and close to 33 million people. It's the global prevalence of AF, and it is going to double in most other places. And more importantly, close to 31% of the patients with AF have at least one hospital admission for a year. And as I told you, AF is a progressive disease. AF contributes to the cardiac remodeling and further progression of AF. In the early days, you have a trigger and patient has multiple episodes of proximal atrial. Slowly, what happens? You have a LA remodeling happens, and you slowly go into the phase of persistent AF. Ultimately, have a significant remodeling, which happens, which puts you in a permanent AF situation, which is very difficult to manage most of the treatment options available right now. If you are first diagnosed AF, proximal episodes up to 7 days and termination is mostly spontaneous, and sometimes you may require a cardioversion. You call it persistent when it is continuous for more than 7 days, and a lot of times you may require a cardioversion, a lot of times in direct cardioversion. And early persistent AF is if AF episodes are sustained more than 7 days but less than 3 months in duration. But long lasting or persistent if it is continuous more than a year, and rhythm control strategies can be adopted. Permanent AF is a one when you have ultimately reached a stage where you no longer can convert this AF into a sinus rhythm for a reasonable period of time, and you may not be able to pursue rhythm control strategies, which are very important. Prevalence of atrial fibrillation progression, there are multiple studies which have quoted multiple numbers, but it averages somewhere ranging from 7.7 to 72%, with average of 30 to 40% progression rate in most of the studies across globe. So consequences of AF progression, not only the AF disease as such, it increases the mortality, it decreases the quality of life, you have more hospital admissions, and you have close to 6.5 times more chances of developing a stroke when it becomes from a proximal to persistent category. What happens when you ablate these patients earlier? When controlling AF symptoms, you know very well there are two strategies for rhythm control. Now we have enough evidence to suggest that rhythm control strategies results in a better long-term cardiovascular outcomes. Catheter ablation as a rhythm control strategy is more effective than a drug therapy in preventing AF progression and is highly effective in reducing amount of time patients spend in atrial fibrillation. A shorter time from diagnosis to ablation is associated with excellent procedural efficacy and reduced cardiovascular hospitalization, and it highlights the importance of early ablation. If you look at a rate and rhythm control, which is a long-standing topic in atrial fibrillation, randomized controls have showed a significant improvement when you are going to use rhythm control as a strategy. Rhythm control is generally associated with lesser outcome when you are going to use ablation. But if you are going to use a rhythm control strategy with the drugs, the problem is the drugs are going to give, although rhythm control of atrial fibrillation is going to deliver a better long-term cardiovascular outcomes, the problem is the usage of drugs. We are going to use a toxic antiarrhythmic drugs which can blunt the benefit you derive from keeping the patient in a sinus rhythm. This is what shown in the AFFIRM secondary analysis. When you have a presence of sinus rhythm was associated with a 50% lower risk of death, the use of antiarrhythmic death to achieve a sinus rhythm was associated with a 50% increased risk of death. So you are not achieving anything by adding these drugs to keep a patient on a sinus rhythm by achieving a rhythm control. If you look at early rhythm control, you know very well that multiple studies showed that it has a significant improvement in patients' overall cardiovascular outcomes. Catheter ablation, we know very well, if you are going to achieve good catheter ablation in the early part of proximal AF, you are going to allow the patient to remain in this category rather than moving on to the persistent AF. A multicenter trials in 29 countries across 29 centers across the 13 countries have shown in more than 255 patients with more than 60 years of age with proximal AF more than 2 years, and they were enrolled to the RF ablation and antiarrhythmic therapy arm. You can very clearly see that RF ablation has significantly reduced number of patients to be progressing to persistent atrial fibrillation. So not only catheter ablation was very useful in progression, it also reduced the AF burden. Catheter ablation was more effective than antiarrhythmic therapy in reducing the AF burden. The another one is when you are going to do this catheter ablation early, you are going to achieve a better results. So that's what ultimately lead to these catheter ablation guidelines. Now, HRS consensus statement says that PVA is a widely accepted and cornerstone AF ablation procedure. Electrical isolation of PVA is recommended during all AF procedures. So if you look at catheter ablation guidelines across, now we have catheter ablation guidelines which say that the patients with proximal AF, if you look at drug options and ablation options stand higher up. Particularly if you are able to achieve a good PVA, you can achieve a significant improvement in the time patient can spend in the sinus rhythm. So now catheter ablation has become a first-line therapy for keeping the patient in the sinus rhythm. All the guidelines today, however, have been influenced by the earlier studies which came from RF ablation arm, which compared antiarrhythmic therapy with RF ablation arm. Now we have a lot of evidence coming from the cryo arm, which is able to put you in a better space and better place to control these patients with atrial fibrillation. The three large studies, the RAFT one, which radio frequency, and Mantra PF, all these studies have shown a better strategy of earlier ablation with radio frequency. But the problem was you ultimately lose a lot of your advantages in the radiofrequency arm because of the complications associated with it. So this was the one reason why still there was a problem in accepting or making a catheter ablation as a primary mode of treatment in patients with paroxysmal AFib to keep them in the sinus rhythm. So if you look at most of the previous first-line studies using a radiofrequency ablation, catheter ablation was associated with 37% reduction in the risk of atrial AF recurrence compared with AAD therapy. So there is no doubt that catheter ablation is more effective. The problem comes because of the repeat procedures and the complications associated with that. The symptomatic AF occurrences tended to be lower with ablation compared with AAD therapy, but they did not reach the statistical significance. This is with radiofrequency ablation. If you look at most of the studies which used radiofrequency for a radiofrequency ablation, the crossover occurred in around 33% of the patients who are randomized to antiarrhythmic therapy. Repeat ablations were observed in close to 33% of the patients who had a ablation done. There was no difference in hospitalization between groups. A relatively high rate of cardiac tamponade was observed in the cardiac ablation arm. A symptomatic bradycardia was also more common when we are using an antiarrhythmic therapy, which is expected. If you look at the cryoablation as first-line therapy, you have excellent studies available now. CryoFirst, which was published in Europace March 2021. Stop AF, which was published in January 2021, and Early AF, again published in January 2021. These are the latest studies. We have a new generation Arctic front balloon, which is available right now to deliver you a better cryoablation results, and the results are good. It used the number of patients used and the criteria used were nearly same. Most of the trials used symptomatic paroxysmal AF, and the major exclusion criteria has also remained same. They preferably taken out the patients who had a structural problem at the LA and the patients who have a persistent or permanent AF, and the patients enrolled, they were reasonably comparable, and drugs used also again reasonably comparable as expected. Flecainide was most commonly used drug, followed by propafenone and sotalol and amiodarone. And if you look at the results, the result is very good. And you know very well the real world management of atrial fibrillation with antiarrhythmic drugs again remains with these drugs. So whatever the drugs used were used in optimal doses with the good drugs. So the study compared both the results. You can see a significant improvement. All these studies have significant improvement in the number of sinus rhythm achievement. So you look at the 7-day holter every 3 months in CryoFirst, or in Stop AF, or in continuous monitoring with intracardiac devices. All these have shown that higher rate of primary endpoint failure with more robust cardiac monitoring during follow-up. Your quality of life and symptoms were significantly better in a cryoablation arm when compared with antiarrhythmic arm. A larger improvements in AF specific quality of life indexes were observed in cryoablation arm when you compare with antiarrhythmic therapies. The safety endpoint, cryo in all 3 trials seems to be pretty good, safe procedure compared with radiofrequency ablation. You can see that CryoFirst, there is no difference was in between antiarrhythmic arm and cryo arm when you look at the safety as a primary endpoint. You can see there was not a higher proportion of patients in ablation form. Like in a radiofrequency arm, you can see that there is a significant portion of the patients who had radiofrequency had adverse outcomes, but in cryo arm, I think it's nearly comparable, both cryo and antiarrhythmic arm as far as safety is concerned. The only problem observed more during a cryoablation arm is phrenic nerve palsy, but fortunately most of these were reversible. There was no significant problem in a permanent phrenic nerve palsy in most of these patients. So to keep in this mind how cryoballoon works, Arctic front was advanced. The cryoballoons were designed for just delivering your pulmonary vein isolation. Cryoballoon is an anatomical approach for PVA. It creates contiguous homogeneous lesions surrounding the pulmonary vein. Using a safe cryo-energy, cryoballoon removes heat from the tissue for a more durable method of PVI. The cryoballoon preserves the extracellular matrix. That's the reason you tend to develop lesser complications. And cryoballoon and radiofrequency ablation are two standard ablation systems used nowadays. You're freezing a tissue with 23 or 28 millimeter balloon, which is available right now for cryo. And while you have point-to-point ablation, which is available with radio frequency. Now, there are circular catheters available. I think most of us, we don't use circular catheters right now, and we deliver most of the burns by point-to-point. Cryoballoon, the one biggest advantage with cryoballoon ablation is it preserves the extracellular matrix. Cryo energy offers you several unique features compared to radiofrequency ablation. A cryo adhesion improves your contact and stability. We know very well once cryo is initiated, your balloon gets stuck to the pulmonary vein. So that the chance of moving is much lesser. So it offers you excellent stability. It preserves extracellular matrix and endothelial integrity and decreases risk of thrombus formation and demonstrates well demarcated lesions in most of the studies. The one advantage with, because these are larger balloons, when you are going to take a 28 millimeter balloon, which we takes in most of the patient, you are able to deliver a good antral ablation, and by creating a good backup, it creates a difficult path for conduction. Yes, 73% of patients had a good posterior lesions, which are very difficult to achieve when you are going to use a radio frequency. So if you are going to look at cryoablation story further, STOP AF was published in 2013 with cryoablation, and close to 12 single center studies were published, and Fire and Ice trial in 2016. The STOP AF was published in 2017. Now we have a good number of studies which have come in approximately AF, and this ultimately are changing the guidelines for managing patients with atrial fibrillation. Now you have a lot of studies which are coming up, which are going to prove that cryoablation as a standard of care in patients with paroxysmal atrial fibrillation to start with. Earlier treatment with catheter ablation has shown to reduce cardiac arrhythmia recurrence. Patients can now be referred for a cryoablation without need for drug therapy failure. And cryoablation is a safe and effective choice as for now. When you compare with radiofrequency ablation, cryoablation gives you a chance of managing most of these patients in the very early part of their atrial fibrillation, thereby preventing progression to a recurrent proximal stage or a persistent atrial fibrillation, which may be difficult to control with most of the strategies right now available. Thank you.
Thank you, Dr. Lawrence Jasiraj, for your excellent presentation on cryoablation for atrial fibrillation. Where do we stand now? Actually, you brought out what are the advantages of using cryoablation when compared to RF ablation by being more safer than RF ablation, and various other factors also you discussed. I think we'll discuss at the end of the session further questions. I think for want of time, I'll move on to the next talk by Dr. Dhiraj Gupta, and he'll be giving us two talks: fire versus ice for AF ablation and management of persistent AFib ablation. So I'll request Dr. Dhiraj Gupta to go ahead with the two talks continuously, and we'll have the discussion at the end of this session. Thank you, Dr. Dhiraj.
Thank you very much indeed for once again for this very kind invitation. So I have two back-to-back talks, so that's probably going to take me better part of half an hour. So I apologize if you get sick and tired by the sound of my voice by the end. There will be a lot of overlap between my talks and the talks from Dr. Gopala Murugan, Dr. Jasiraj, and Dr. Rao, who have just delivered talks before me. So I apologize for that. But there are some points that need to be reiterated, and so it's probably worthwhile doing that. So before I start, it's well worth reminding ourselves how far catheter ablation has come today. It's exactly 40 years since the first catheter ablation procedure was performed clinically. In fact, two operators performed this almost simultaneously, Dr. John Gallagher and Dr. Melvin Scheinman. They performed these procedures in which they performed DC cardioversion of the atrioventricular node in patients with permanent atrial fibrillation and fast ventral response. So this year, our field has officially entered middle age. So along with middle age should come maturity. And in many ways, we have matured as a field. And there are lots of advances that have occurred. Some of the technologies have come and gone, fallen by the wayside, whereas others have been here to stay. So let's concentrate on those which are left with us. Now, what is absolutely not in doubt is the central role of pulmonary vein triggers in the genesis of atrial fibrillation. This is certainly true for paroxysmal atrial fibrillation, but increasingly so for persistent and long-standing persistent atrial fibrillation as well. So much so that 20 years after this discovery by the group from Bordeaux, even now, last year's ESC-AF guidelines say that patients with persistent atrial fibrillation, pulmonary vein isolation should be the bedrock of the procedure. Anything over and above is really experimental. It's not backed unequivocally by good quality randomized controlled data. And so, as far as possible, one should resist the urge of performing empirical ablation other than pulmonary vein isolation. Now, there are several tools which are available to isolate pulmonary veins this year. Obviously, radiofrequency ablation has been around for a long time, and that remains the cornerstone of this procedure. And most centers would have expertise in performing focal radiofrequency ablation. But there are also an increasing number of single shot devices which can do this. So we've already heard an excellent talk about cryoballoon PVI with the Medtronic Arctic Front and Arctic Front Advanced Balloon. But you may be aware that Boston Scientific have come up with their own version of this called the Polar X balloon. And of course, we have the laser balloon, and now off late, there's also a radiofrequency heliostar balloon, which has been developed by Biosense Webster. And of course, we're not even going to talk about PFA or electroporation, which is going to be perhaps the most important ablation modality in the years to come. Now, what would be the features of an ideal pulmonary vein isolation tool? Obviously, it should have good efficacy and safety. The procedure time should be short and also predictable, so you can list a particular number of patients for a day. The learning curve should be short, and you should not be that dependent upon operator skill. Ideally, what you want is for any operator to have a certain procedure success rate and a complication rate, rather than them being dependent totally on operator skill. Of course, the setup should be easy. The easier it is, the more it is possible to take the procedure to less experienced operators, to smaller cath labs, without relying on multiple cardiac physiologists to help you. You should be less dependent upon general anesthesia, ideally, and less dependent upon esophageal monitoring. And of course, all of this will tie into the possibility of letting the patients go home the same day, and of course, it becoming cost effective. But of course, if you are really asking for everything, what you want is the tool to be versatile as well. You want it to be not only successful in isolating the pulmonary veins, but should also be able to do other things should the need arise during the case. Now, single shot technologies have many of these features, the ones which I have shown here. And so it's no surprise that there has been a huge expansion in their use in the last 10 years or so. So much so that even here in Liverpool Heart and Chest Hospital, this has been our graphs, if you like, from 2009 to 2015. Already in that short 6-year period, cryoballoon PVI went from 0% to 50% of our AF ablation activity. So it's now at about 50 to 60%. So there has been an increasing use of cryoballoon in a number of centers for the reasons I've just mentioned to you. Now, trials, and we've had some, some excellent data which have been presented already. Trials have shown that both cryoballoon and radiofrequency ablation are largely similar in terms of efficacy. The original Fire and Ice study, which was published a few years ago, showed that to be the case. But of course, the more recent Circa-Dose study, which compared latest generation cryoballoon, which is Medtronic Arctic Front Advanced, versus contact force sensing guided radiofrequency PVI, largely using CARTO, showed the same thing, that the success rates were very similar between the two technologies. Of course, there are differences between the two. We all know that procedure times for cryoballoon PVI are on average a half an hour to 45 minutes shorter. The left atrial dwell time is shorter, but the fluoroscopy time is longer with a cryoballoon. But obviously, you're not relying on 3D mapping quite so much. The most important thing is that whilst the randomized controlled trials have shown both of the technologies to be equally effective, in real life, things are somewhat different. And this was an excellent study by Rui Providencia and colleagues who published this a few years ago now, essentially looking at the comparing the efficacy of radiofrequency ablation and cryoballoon ablation across several centers in France. What they saw was that cryoballoon had overall, as a group, had higher success rates as compared to radiofrequency ablation. But then they drilled down the data further to look at the success rates depending upon the experience level of the hospital and the operator. So the procedure volume for the operator and the hospital. And what you can see here is very striking. That with cryoballoon, it did not matter much whether the operator did less than 25 cases a year or more than 100 procedures a year. Success rates were about 70 to 80%. Whereas with radiofrequency ablation, the opposite was the case. If you were a very experienced operator who did over 200 cases a year, your success rates were over 80%. On the other hand, if you were a relatively inexperienced operator, then the success rates were very poor, less than 40%. And the same thing has been shown by Jason Andrade in terms of the Circa-Dose study sub-analysis as well. So he's presented those data in international meetings. I don't think the paper's been published yet, but again, the same thing. With cryoballoon, it doesn't matter who's doing it, success rates are similar. With radiofrequency ablation, the procedural volume of the operator, the experience of the operator makes a huge difference. You can get a fantastic result, perhaps better than what cryoballoon can achieve, but that's a minority of operators. In most operators' hands, the success rates with radiofrequency ablation will struggle to match those of cryoballoon PVI. Now, of course, a big problem in radiofrequency ablation used to be down to the lack of standardization of the procedure. And of course, things have changed now since the publication of the so-called closed protocol. So we've been following this closed protocol for a number of years in Liverpool. And in fact, we were one of the first sites that validated the ablation index targets as well for this. And we have seen that if you were to perform AF ablation with a particular protocol in which you pay close attention to the intertag distance, the stability of the catheter using a steerable sheet, and if you look at ablation index targets guided by generator impedance drop, then the success rates are very, very good and well over 80% single procedure success rates. There are attractions of the cryoenergy, and this has already been covered by Dr. Jesuraj, so I won't go into too much of detail, but essentially you can see the catheter stability is obviously an important issue because it means that you've got less chances of reconnection or leaving a gap because the catheter adheres to the pulmonary vein antrum. Safety, again, we all know that the cryo technology is safer because of the leading wave of hypothermia and how when we sometimes use it for AV and RT, that comes in quite handy because you can do cryo mapping before cryoablation. Even when we're doing cryoballoon PVI, you might get phrenic nerve palsy, but the moment you stop your refrigerant flow, ideally through a double stop technique, the phrenic nerve injury can regress very quickly. With radiofrequency ablation, obviously that is less forgiving as a modality. And there's also possibly a decreased risk of stroke. And again, this is something which Dr. Jesuraj showed data that histologically how the lesion looks in a radiofrequency lesion compared to a cryo lesion is quite different. There's less endothelial disruption and less propensity to develop thrombus on the surface as a consequence. So of course there are other benefits with cryoballoon PVI as well. So as I said, it's safer because it's quite difficult to cause tamponade with a cryoballoon. So once you've done a safe transseptal puncture, then you're very unlikely to cause tamponade with cryoballoon compared to radiofrequency. Procedure time is short, and so you could have a higher lab throughput. And of course, the setup is easier and the learning curve is shorter. So even if fire versus ice showed similar results in terms of efficacy, what we have seen is that the other advantages with the single shot technologies such as cryoballoon trump the advantages of the radio frequency ablation. Of course, there are limitations. It's not a versatile tool. It usually, it does what it says on the tin. It isolates the pulmonary veins very well. And yes, people have tried to use it to isolate the posterior wall and do other stuff. But actually speaking, it's meant to isolate the pulmonary veins, and that's what it really does well. Everything else is less good. But it's not very versatile. So if people have anatomical variants of the pulmonary veins, such as left common pulmonary vein, such as here, or if you have a right common pulmonary vein, or a common pulmonary vein, so up to about 15 to 20% of patients have some kind of variation in pulmonary anatomy, well, then cryoballoon PVI is less good. And I know of several centers that routinely perform CT scans in all their patients, and anybody with a large tubular common pulmonary vein is not offered a cryoballoon PVI for this reason. I know some centers have shown that it doesn't impact upon success rates with cryoballoon, even if you have a common pulmonary vein. But certainly in our hands, the results are less good because the isolation tends to be a bit more distal. So if we find that somebody has a tubular common pulmonary vein, either beforehand, on CT scan, or even during the procedure, we just quickly move over to radiofrequency ablation because we know that success rates with cryoballoon are going to be suboptimal. What does the cryoballoon ablation mean for the patients? It's just a short video from one of my procedures. We always use vascular ultrasound anyway to guide access, as I'm sure you can see here. And once you've got access, then we just isolate the pulmonary veins one after the other, starting with the left upper, as you can see here, and then going on to the left lower. And of course, you can see the gradual delay in the in the pulmonary vein, as you can see here. And then of course, you can see the isolated PVPs coming through. You can see quite clearly that the PVPs are isolated because you can see the sinus rhythm. And then from time to time, you're getting the pulmonary vein activity as well. And of course, during the right-sided balloon pulmonary vein isolation, we always look carefully for phrenic nerve function because that is the commonest complication that you can encounter with these patients. It's almost always reversible, but still, the sooner you pick up on it, the easier it is to get on top of it. Now, I've already shown you this, that the patients often go home the same day. So radiofrequency ablation, again, as I said, it has to be standardized if you really want to get good success rates. And the important thing is to make sure that you're following the closed protocol very carefully. So you want to make sure that the lesions are contiguous, as it is in one of my cases here. You've got ablation index 550 here, 400 on the posterior wall. And if you do that, then you can get a very good antral PVI with a good success rate and very good outcomes. So what are the points you might want to consider when you're choosing radiofrequency or cryoballoon, especially as a patient? I think availability of general anesthesia is quite important because radiofrequency ablation does take a bit longer than cryoballoon PVI. So the patient has to be still, to ensure that the map remains stable. So if you've got the availability of general anesthesia, then radiofrequency ablation would win hands down in my hands. But if you're an experienced operator, that's great. But otherwise, if you don't have general anesthesia and or the operator is not very experienced, then you're better off going for a cryoballoon PVI, and you're going to get a reasonably good result. So to summarize, PVI is effective and safe for most patients now in most catheter laboratories. Single procedure efficacy is usually about 80% for paroxysmal atrial fibrillation, 60% in persistent atrial fibrillation, but I will go into that in a bit more detail in the second talk. And in experienced hands, freezing and burning technologies are equally effective, but in relatively inexperienced hands, freezing technology is the way to go. So thank you very much for that. I think I've managed to finish this talk in time, just in time. So I'll go straight on to my next talk then. So just bear with me, please. A bit over here. Okay, here we are. Right. Okay, so what should we do for persistent atrial fibrillation? Again, this is something which we have already covered quite nicely in the previous talk, so there will be a bit of overlap, so I apologize for that. But the important thing to say is, what persistent AF are we talking about? Now, we know that persistent atrial fibrillation is anybody who's been in AF for longer than 7 days. But somebody like that who's had AF lasting for 10 days, he's very different from somebody who's been in continuous AF for 2 years and whom we have not been able to restore sinus rhythm in spite of amiodarone. or somebody who has reverted back to AF within a week of cardioversion, patient who has left atrial enlargement, structural heart disease. They all persist in AF, but we all recognize that these are completely different substrates. So it's important to qualify this question that what persists in AF are we faced with when we have a patient in front of us. Now we know, of course, that pulmonary vein triggers are extremely important for paroxysmal AF. And this has been shown before, but it has also been shown that even with persistent and long-standing persistent atrial fibrillation, pulmonary vein antral triggers continue to be the predominant focus or source of the triggers. So that is important. Now, the question arises that if 90% of triggers arise from the pulmonary veins, why are success rates with pulmonary vein isolation alone not 90%? And the reason for that, for many years, used to be that pulmonary vein isolation was not durable. The technologies that we had were unable to durably isolate the pulmonary veins. And so pulmonary vein reconnection used to be the rule rather than the exception. And many studies that looked at patients coming in for protocol mandated repeat procedures saw that you could get reconnection in as many as 2/3 of patients. They may or may not be symptomatic with AF at that time, but reconnection was the rule. And so you couldn't really say, whether or not the pulmonary vein isolation would have been effective or whether any additional strategies were needed, because you hadn't even achieved pulmonary vein isolation in the first place. So how can you critically evaluate the role for anything in addition to pulmonary vein isolation? Things changed a lot since the publication of the closed ablation protocol from the group from Bruges. And as I've said, this looks at basically two things. The lesions have to be contiguous. The most important thing is contiguity, so you don't leave gaps. And the lesions have to be optimized. So, of course, ablation index is one index which can use to do that. So you can look at targets anterior posterior wall, or you can use LSI on the velocity or the precision platform. But essentially, the idea is to have contiguity. And if you have a durable antral PVI, even in persistent AF, the success rates can be very good. And this is what we showed a few years ago, in fact, in the PRAISE study, which we had published, that if you had durable pulmonary vein isolation alone, you did nothing else, you just did durable pulmonary vein isolation alone, you followed up these patients for 12 months, you had success rates of 80%. So that's not bad for persistent atrial fibrillation. So that really shows us what is the ceiling of success that you can achieve with just PVI alone. If you isolate these pulmonary veins antrally, you can get pretty decent success rates. You're only left with 20% of persistent AF where you really have to do something. So much so that now most of the patients who come to the catheter laboratory for recurrent atrial fibrillation in many laboratories, including our own, have durably isolated pulmonary veins. So so it is a real problem we're getting now, because in the past, it was very easy for us to list patients for repeat procedures because we used to find pulmonary vein reconnection and used to isolate the pulmonary veins, and the patient used to do very well. But now the converse is the truth, because when you bring these patients back to the labs, very often the pulmonary veins are isolated, or you might have a little bit of gap in one of the pulmonary veins. That's not causing the patient's atrial fibrillation. So you're then stuck as to you don't know what to do. Do you do posterior wall? Do you do left atrial appendage, et cetera, et cetera? And that's what I'm going to be trying to cover in the rest of the talk. But the important thing is that whatever you do in these patients, the success rates are not that good. And that has been shown that once you have somebody with recurrent atrial fibrillation who've got isolated pulmonary veins, the success rates are worse. These patients have far worse prognosis than patients who had some evidence of pulmonary vein reconnection. And interestingly, these patients have lower voltages in the baseline anyway. So these patients, they are people who are likely to have substrate-driven AF, more scarred atrium, where even if you isolate the pulmonary veins, the AF would continue to be a problem. So then you could do additional lesions, and there are lots of candidates for this. You can do anatomical ablation, i.e. one size fits all, everybody gets posterior wall or roof lines, floor lines, etc., etc. Or you can do it tailored or individualized to the individual patient based on a fixed substrate, such as low cafes or low atrial voltages, or a dynamic substrate, such as rotor mapping or firm mapping, etc. Now, many years ago now, we published a meta-analysis of all the catheter ablation strategies for persistent fibrillation, and we saw that the success rates were higher if the pulmonary veins were encircled, and especially if they were confirmed to be isolated. And also a limited amount of additional linear lesion within the left atrium, not in the right atrium, but within the left atrium, it did improve success rates. And so we had designed this SMAN-PAF trial, which is the multicentric randomized trial looking at different ablation strategies in patients with persistent atrial fibrillation. So PVI alone or PVI plus left atrial linear lesions, which included mitral line, roof line, and the right atrial flutter line. All procedures were performed with CARTO, 3D mapping, contact force sensing catheters. And we got pretty good acute success rates. Everybody had pulmonary vein isolation at the end. 90% of the lines had bidirectional block at the end. And then what we saw, however, was it made no difference to the success rates. The success rates were about 2 in 3, whether you had PVI alone or whether you have PVI plus linear lesions. In fact, patients who had additional ablation had longer procedure times, longer ablation times, longer fluoro times, with no additional benefit. And this was very similar to the STAR AF2 trial, which have just been discussed as well. So the strategy of empirical linear lesions in the left atrium has now kind of died its death. What about posterior wall isolation? And that was a question that Narasimhan discussed earlier as well. It is, again, controversial. A lot of people believe, and I'm one of them, that the posterior wall is an extension of the pulmonary vein sleeves, or the vice versa. Pulmonary vein sleeves are an extension of the posterior wall architecture. And so many triggers can lie within this area. And if you were to successfully isolate this area, then you might enhance the success rates. This excellent meta-analysis published by Prasander group a couple of years ago showed that the results are mixed. There were 1 or 2 studies that showed that it was better, a couple of studies that showed it was no good. There's one study which showed it was worse. So we still don't know for sure whether or not this strategy improves outcomes. And so we are now doing this randomized controlled trial, which I discussed earlier, in which every patient with advanced persistent atrial fibrillation is going to be randomized to one or the other. And everybody gets a loop recorder to look at the AF burden pre-ablation for 2 months, and then compare that with post-ablation for up to 3 years. You could isolate the appendage, and again, there have been a meta-analysis which has looked at this. There was the study, BELIEF study, published by Luigi DiBiase a few years ago, which showed that it was helpful in improving outcomes. There were a few other studies which followed suit, but again, by and large, the jury is still out. This meta-analysis suggested that left atrial appendage isolation improves outcomes, but that's still not a strategy that is routinely followed across the globe, not least because we know that once you isolate the left atrial appendage, then the risk of left atrial appendage thrombi and stroke increases exponentially. So if you're isolating the left atrial appendage, you really do need to be thinking about occluding the appendage in the same sitting. You could perform an individualized lesion strategy by looking at low voltage areas in the left atrium and targeting them, so-called BFA strategy, box isolation or fractionated atriograms. Many studies have been done looking at this, but once again, the jury is still out. We don't know whether or not this works. In fact, a randomized controlled trial published recently in Journal of American Heart Association showed that it makes no difference. So if you were to randomize patients with low voltage areas to either ablating them or not ablating them, they did equally badly. But what's important is that both groups did much worse than patients who did not have low voltage areas. So if you have any evidence of low voltage areas or scarring in the left atrium, it's bad news because it means that the outcomes are likely to be less good. But isolating those areas, ablating those areas does not improve outcomes. So it's something which increasingly is falling out of favor. And you may have heard about the DCAF2 study as well, which was recently presented by Nassim Marouche. Now, originally, when the DCAF1 study was published, it excited everybody because it showed that the outcomes of following AF ablation were less dependent upon whether the patient had paroxysmal or persistent AF, or more dependent upon whether the amount of MR atrial scarring that was seen on cardiac MRI. Then the DCAF2 study was designed, and we were part of that as well, in which every patient had an MRI scan, and we looked at areas of scarring or as seen by MRI. These patients were then randomized to either having those areas ablated or not, or just a standard PVI strategy. And then everybody had a follow-up. And what essentially, the 12-month follow-up showed that there was absolutely no difference in those patients who underwent additional ablation compared to those who did not. In fact, if anything, there was a higher incidence of complications such as stroke in patients who had additional ablation. So again, this is a strategy which is falling out of favor. What about vein of Marshall ethanol infusion? That's again something which a lot of people are now trying to deal with some success. We know that vein of Marshall can be arrhythmogenic, especially in patients with persistent atrial fibrillation. And now we can access that area not only endocardially by catheter ablation, but also epicardially through ethanol ablation. So as with most things in electrophysiology, this was led by our colleagues from Bordeaux. So, you know, Michel Hesseger's lab still continues to be on the forefront of everything. And they are the ones who showed that it's perfectly reasonable to do this safely. And also it improves the outcome. And certainly in their case, it is very much a part of their routine strategy. And this was a study that was published probably about last year, which looked at a multicenter randomized controlled trial in patients with persistent atrial fibrillation who were randomized to either having standard catheter ablation or catheter ablation that included ethanol ablation of the vein of Marshall. And as you can see, the outcomes favored the vein of Marshall ethanol ablation. And overall, the arrhythmia burden was lower at 12 months, at 6 months and 12 months in those patients who underwent vein of Marshall ethanol infusion. So to summarize, I think high quality, durable pulmonary vein isolation alone is sufficient in the majority of persistent AF, certainly in early persistent atrial fibrillation. The exact role of additional posterior wall ablation remains uncertain, but we are, other trials are underway. The ethanol vein of Marshall ablation appears promising, as is left atrial appendage isolation. However, there is no clear mandate to do either of these as a routine procedure, certainly for first-time ablation. I think it's a bit much to do either of these initially. Scar-guided ablation appears to have a limited role, whether you are guided by electrogram-guided scar low voltages or MRI guided scar. Yes, probably limited role. Well, thank you very much for your attention, and I'll be very happy to take any questions.
Thank you very much, Dr. Dhiraj Gupta, for your excellent presentation on fire versus ice for AFib ablation and also management of persistent atrial fibrillation. And what is your view on that epicardial ablation when there is a breakthrough through the septopulmonary bundle? Sometimes recurrence can occur following AFib ablation. And what type of mapping catheter you use? HD grid catheter, I don't know, may be very useful in finding out the gap very easily, and you can get rid of the gap and then we can do a successful ablation. And also, why the right phrenic nerve palsy occurs more commonly with the cryoablation when compared to the left phrenic nerve palsy? And also, if when you suppose if you analyze the time to pulmonary vein isolation, there were some studies that if the duration is a little longer, then we have to again go for a redo ablation. I don't know, is that okay, or I want your view on that also.
Yeah,
Thank
sure.
you.
Well, yeah, thanks, Dr. Chandrasekharan, for those questions. Let me take them one by one. Well, first of all, in terms of my experience with the HD grid catheter, I agree with you. It is an excellent catheter and really helps you home in onto the areas of interest. And yes, the intraatrial septum, especially if there's a scarred area close to the way you've had transseptal access in the past, it can often be the source or often the critical isthmus for biatrial flutters. And if you ablate that area, you can get really good results. And the HD grid catheter is excellent. We also have a lot of experience now with the rhythmia mapping system, with the Orion catheter and using rhythmia 3D mapping. And once again, just like the HD grid catheter, it gives you very high fidelity signals, which allow you to quickly home in on the arrhythmia mechanism. Now, in terms of your question about the phrenic nerve palsy, well, we know that the right phrenic nerve often lies between the right superior pulmonary vein and the superior vena cava. And depending upon how the right inferior pulmonary vein is oriented in an individual patient, sometimes the phrenic nerve can lie very close to the anterior surface of the right inferior pulmonary vein as well. So if you have a large diameter pulmonary vein, usually right superior, it's quite easy to deep throat the balloon and to encounter the phrenic nerve that way. Now, on the other hand, the left phrenic nerve actually lies anterior to the left atrial appendage. So it's pretty unusual that you are going to encounter the left phrenic nerve if you're isolating the pulmonary veins. Interestingly, there have been some case reports of left renal palsy while operators have been performing cryoballoon to isolate the left atrial appendage. So there was this excellent, very interesting series from Turkey published a few years ago, in which they used the balloon not only to isolate the four pulmonary veins, but also to isolate the left atrial appendage in patients with persistent atrial fibrillation. And those patients, they had, and those, I think they had one or two patients who had left renal palsy. So as long as you are sticking to just the warfarin ridge and you're performing ablation distal to, posterior to that, you should not encounter the left phrenic nerve.
And actually, you said no, nearly 30 to 30% of the patients, they have an extra pulmonary vein. Maybe instead of superior, inferior, there will be some middle vein and with a small ostium. And when you do the cryo balloon for ablation, in what percentage of patients you have to resort to additional RF ablation also?
Yeah, sure. But that percentage is very small. I think in most of the cases, you will finish with isolating all four veins. My concern in some patients with altered pulmonary vein arrangement is that your isolation may not be antral. So if you've got a common pulmonary vein on or your left side, or you've got a large right upper pulmonary vein, or you've got a right upper and a right middle pulmonary vein that have joined together to form a big antrum, your balloon will only fit very distally. So you will still have pulmonary vein isolation, but it will be very distal. And very often when these patients come back with AF recurrence and you then perform a 3D mapping based procedure, you will find that you needed to create far more antral isolation than had been performed even following a successful cryoballoon PVI.
Thank you very much, Dr. Dhiraj. I think hand over to Dr. Jaishankar for the final conclusion.
I have just one last query with Dr. Gupta. Given your large experience with both modalities, what is it that you advocate now as a de novo procedure? If somebody walks in.
Yeah, well, that's a good question. So it again depends very much on the individual operator. I think every operator would know what they are comfortable with and what are the best results possible in their hand. Personally, I love focal radiofrequency ablation. For me, the versatility it offers me is unparalleled. And for me, that would be the number one choice, especially if I have access to the general anesthetic. However, for many operators out there, radiofrequency ablation may not be the best procedure. It may be that the cryoballoon PVI will give them a pretty good result safely and quickly. So that may be what they advise the patients.
Do you feel there's an advantage of one over the other by any chance, because you've been doing RFA for close to 2 decades and this is a very new technology that's just come up?
Yeah, I think radiofrequency ablation, when performed well, it is still the most effective. So I didn't have time to present our own data. In fact, there was a study we published called VISTAC study, which was a 11th European Center study, which I was the PI for. And we saw that the single procedure, the success rates with a closed protocol PVI at 12 months was 90%. 90% as seen with conventional rhythm monitoring. Because these patients had weekly trans-telephonic monitoring as well, the real success rates were about 82%. So not 90%, but 90% of these patients did very well. And repeat ablation was necessary in only 5% of the patients. So we feel that you couldn't get that kind of success rate with just cryoballoon PVI.
Cost effectiveness is also better with the RF ablation when compared to the cryo.
Sorry?
Because cryo ablation is costlier and the procedural cost will be more with the cryo when compared to the conventional radiofrequency ablation.
Yeah, well, if that is true, as you're saying in India, then clearly that would also favor radiofrequency ablation as well. Obviously, not at the cost of a huge difference in success rate or complication rates. Obviously, if the two are equivalent, then the cost will will make a big difference in determining your decision.
Yeah, thank you very much.
I think we are at the fag end, or rather the end of the session. Thank you very much. Ever so pleasant and nice to hear you, sir. And
Same here.
very lucid.
Thank you very much for inviting me, Shankar, and love to you all.
Same here.
Thank you.
We'll probably catch up in person next time around and probably do a few cases with you here in Chennai.
My pleasure.
It will be a pleasure to watch you and watch you the way you work. Thank you again, sir. And thanks, Dr. Casey and others in the panel. And we finished well on time. Go for the dinner symposium, have some booze, have some good food, and reconnect tomorrow morning 10ish. Bye-bye.
Thank you, Jay Shankar, and thank you, Dr. Dhiraj. Thank you very much.
Bye.